have atrial fibrillation. I have no risk factors except 69. Now, I'm CHA2DS1. Do I take an anticoagulant? No. Why don't I take an anticoagulant? Because I travel about all over the world, taking pills with me, remembering the pills, difficult. Will I take them on time? Almost certainly not. Do I have anything wrong with my left ventricle? Is my left atrium large? No, they're not. So for myself, or at least for my doctor advising me, he said, not yet. But it's coming. It'll only be another year or two, still CHA2DS1, and then I'll have to take a pill. But you have to look at cases case by case.
So as a physician advising him, is John standing in front of a mirror and say, what is your advice? So, please.
Hi, I'm Diener. I'm a cardiologist from Liverpool. Just a couple of questions, one for Prof. Camm and one for Dr. Ilse. The first question is, John, do you think time is coming where we're going to be using biomarkers to further risk stratify patients with atrial fibrillation? Not just use very close markers like CHA2DS or CHA2DS. The other question is, intracranial hemorrhage is a huge spectrum. You get some patients who have traumatic subdural hematoma because of an accident. They may happen to be on medicine at that time. And on the other hand, you have somebody who has spontaneous intracranial hemorrhage because they have amyloid angiopathy. So which are the patients, where would you draw the line? This is the patient I'm not going to start an oral anticoagulant again.
Should I start? The patient with a lobar cerebral hemorrhage with amyloid angiopathy, I would not start on oral anticoagulating again. I think that, as neurologists, I think that subdural hematoma is simple and it's not serious. It is indeed. We know from the RELY trial that 29% of the patients were dead by 30 days, even with a subdural hematoma, probably because some of them are not restarted on oral anticoagulation. But it is a serious thing to get an intracranial bleed, and we don't have any evidence for randomized trials. These patients have been excluded for all trials, and I think there's a need to back up of randomized trials. I know in Holland they're running a trial comparing apixaban, I think with nothing, in patients with intracerebral hemorrhage. And I think we should, there's quite a lot of these patients as well. Problem is that they are quite bad after the intracerebral hemorrhage, but we should try to do randomized trials in these patients as well.
John, biomarkers?
With regard to biomarkers, I think there are a couple of arguments against them at the moment. One is that most of them have been assessed in populations which are anticoagulated. So quite reasonable on the bleeding side perhaps, but perhaps not so convincing on the thrombosis side. On the other hand, I think it's inevitable that biomarkers will come into use. Currently, there's a problem because clinical risk scores are immediate. You can see the patient then and then and decide whether you'll anticoagulate the patient. If you want a biomarker, you've got to draw the blood, send it somewhere, get the result, get the patient back, and decide to anticoagulate the patient. So I think currently we prefer the immediacy, but I think biomarkers are definitely on the way. Very convincing evidence.
I'll just stand up. I'm David Thaler, a neurologist from Boston. The contraindication with mechanical valves, I think, comes from the observation of a subgroup in the dabigatran studies, not observed in the other NOACs. I don't understand the mechanism of that. I'm assuming it's a spurious random subgroup.
No, it's not. You are wrong, yes. First of all, the data doesn't come from the large phase 3 randomized trials because they excluded mechanical heart valves, all of them. It comes from a study which was called Realign, which was specifically done to test doses for a larger study in patients with mechanical heart valves. They used the dabigatran in a range of doses going up to 330 milligrams twice a day, so up to very large doses. And they found that the rate of thrombosis and the rate of hemorrhage were both much higher in the group taking dabigatran compared with the group taking warfarin. These were patients post-operatively, either acutely, just having had a mechanical valve, or 3 to 6 months down the line. In both groups, there was adverse effect from the dabigatran. And this is backed up by a lot of basic science. For example, if you test thrombin generation in the laboratory, essentially if you stimulate thrombin generation, you get a little peak like that. If you put some carbon tissue, some Dacron, some Teflon in the tissue bath, this goes up 3 or 4 times. If you then add dabigatran, you need 3 or 4 times the level of dabigatran to bring thrombin generation back to normal. Now, there's some evidence that that's not exactly the case with factor 10As, and perhaps a combination of 10A and factor 2 inhibition would be helpful. Nobody's tried it. As far as I'm aware, there are no 10A trials underway with mechanical heart valves. But there's a lot of interest in factor 11, because if you chuck carbon in thrombin generation with factor 11 inhibitors, nothing happens. So people are very interested in that arena.
Can I challenge all 4 of you about the availability of a reversal agent? Does this have an impact on your prescription behavior? So that we have now a reversal agent for the dabigatran, but not yet for the 10A inhibitors? Who wants to take this on? Dorte?
No, I don't think so. We already know from real-life data that we see indeed quite few intracerebral hemorrhages after the introduction with NOx. But of course we're going to see more because we put more and more elderly and fragile patients on the therapy. But I think we already know from the trials that if you get an intracerebral hemorrhage on oral anticoagulants, you are doing quite bad, whether you get warfarin or you get an ORAC. And like the first patient I showed with this hematoma enlargement, now we of course have the antidote, and I think you should use it if the patient gets in early, but it doesn't make me make any change.
Well, can I challenge you again with data, which are not published? But the mortality in people who have an intracerebral bleed on the dabigatran with the reversal agent is 9%.
Okay.
And without the reversal agent is 46%.
Okay.
So does this impact your decision?
And could I just ask, is that a randomized control trial
No.
or a registered?
Well, I don't think you can randomize. If someone has a bleeding into the brain, there's no way you can randomize if you have a reversal
but
agent.
it's propensity score, or it's register-based data. This or
No, well, all it basically did repeat CT to look at bleeding growth, and there was only 1 patient out of 12 who had a growth of the bleeding, and 11 out of 12 didn't have a lesion growth with the reversal agent. So it's just accepted for publication. There was one more question? Well, everyone who has a bleeding on the dabigatran got the reversal agent. So I think what we know from the published literature on people with at least warfarin-induced cerebral bleeding getting PCC, the mortality was also 45%. That's Canadian data from the blood supply data bank, which were published 2 or 3 years ago. So PCC obviously has no impact on mortality.
My another question also for valvular EF. We have a lot of study why we can use in our case, not mechanic valvular.
I think it's really important that we appreciate what is meant by valvular atrial fibrillation. In fact, the term is very misleading because it makes doctors think it's any valve problem. But it's only 2 valve problems currently in that category. One is a mechanical heart valve. The other is moderate to severe rheumatic mitral stenosis. The Americans also include a bioprosthetic valve in that category, especially early following the insertion of the valve. but no other valves. So aortic stenosis and regurgitation, mitral annuloplasty, mitral repair, and all of those sorts of things are not valvular AF. They're AF occurring in patients with these valvular conditions, but they're not valvular AF. And you can use a NOAC in those. These patients were recruited into the phase 3 trials. There's ample data, particularly if you look at them in meta-analysis. And there are now meta-analytic data showing that none of these valve problems constitute any particular difficulty with NOAC therapy. So you can certainly use NOACs in these patients.
There is a wonderful review paper by John Camm in the European Heart Journal. It's really worthwhile because he discusses in very much detail this problem, what really constitutes a contraindication for NOACs.
Can I continue?
Yes.
My another question for Professor Everesting. You said that the hemorrhage stay the same level. You said you thought because we continue to use the anticoagulant, so the hemorrhage cerebral stay. Do you think about the amyloid angiopathy? Maybe our patients are older now, and we have, in my experience, we have a lot of hemorrhage, cerebral hemorrhage because of amyloid.
Yeah, it could be that, but but we don't have any evidence because this is based on quality registry data, and we don't have subclassification of the cerebral hemorrhages if they're amyloid associated or not. And this, of course, but I would guess that in a lot of countries we've got more and better primary prevention here. But this will be this I would guess that we will have quite much less ischemic strokes, cardiomyopathic strokes. But on the contrary, we will have more cases that will be even NOAC associated intracerebral hemorrhages with that. So it is. Yeah, you usually need studies and randomized and so on. But yeah, of course, but it would. I don't know really where to. Of course, this would be a primary prevention study and finding individuals with atrial fibrillation and doing MR on those patients and when starting on them on NOACs. Yeah,
I would like to just comment. I think it's very important to differentiate between patients who had a symptomatic bleed and patient who has never had a symptomatic bleed. It's incidental finding that you find these microbleeds. These patients have been in the studies as well, the randomized trials. And if you are old, your risk of ischemic stroke is much higher than the risk of an intracerebral hemorrhage. So we should not be afraid of intracerebral hemorrhage in the primary prevention and not even in the secondary prevention with patients with ischemic strokes. It's only patients with a symptomatic bleed.
But I think about different pathologies. If you see microbleeds in the cortical area of the brain, of course, this is something absolutely different from hypertensive microbleeds in other regions. And I think these are patients who I would not put on anticoagulation if I see plenty of cortical microbleeds, which are presumably sign of amyloid angiopathy. Because
we have studies going on now.
Again. They will bleed again.
If that's the case.
No, we have more people asking, so if there is time left, please.
I'm Christina Cruz from Hello Hospital here in Copenhagen. I have a question regarding the microbleeds, because actually it's a clinical dilemma. Should we do an MRI scan on all our patients with atrial fibrillation before we introduce lower warfarin?
Of course, we cannot afford to do this, to make an MRI of all patients. But yes, it's what we would like to do. What we did in a region near Munich, for example, in Eversberg, we have a study there, and we made 1,000 MRIs, and it's very interesting what we found in those patients. But really, the amyloid angiopathy with cortical microbleeds is very rare.
Or is it just so that we don't notice it because we don't do the MRI?
if we really try to distinguish the hypertensive bleedings in typical regions of the brain and the amyloid angiopathies with other regions and a high bleeding, higher bleeding load, then it's rare. Yes, according to my experience, it's rare.
There is
But
a
we
much
see these
cheaper way
patients.
to address this is, remember, this is dominantly inherited. So you take a family history. And if there is a history of early strokes, early dementia, or early intracerebral bleeds in terms of age, then this is suggestive. And in these cases, I would really recommend to do imaging, but otherwise not.
Because we do find a lot of patients who do not have a family history and who do the amyloid angiopathy. So we're a bit worried sometimes. So we actually do it on a wide selection.
Good.
Should we include this in any clinical trials?
Yeah, it is not done in the AFib trial, but in the two ESUS trials, we have baseline MRIs from, I think we have 2,000 out of 6,000, and then we have 3 to 4 years follow-up. So we will see how they do in terms of bleeding on anticoagulation. So I give you the answer in 3 years from now. Good. Can I challenge you with a final question? We had this business of falls. So we have this 80-year-old Parkinsonian patient, and she falls once a month, and she already had a hip fracture and has now a new hip. Now, what is the choice? Is it the bigger drum because we have a reversal agent, or is it LAA occlusion?
Well, I think we have to recognize that a fall followed by an intracranial bleed could occur, and it could be a long time before the patient ever got near a reversal agent. So if it happened in front of the doctor and he had the reversal agent in the fridge behind him, then obviously it would be a very good way to treat the patient. I would personally prefer the interventional approach for that particular patient.
Also because
Okay.
the patient with Parkinson falls like this.
Smack on the head.
Good. I think there are 3 lessons for the cardiologists in the room. Whenever you have to decide whether you can initiate anticoagulation or not in someone who had an intracranial bleed, talk to your neurologist, because he is the one. And you also had something also. If someone has a history of falls, talk to your neurologist, because there are falls which are not dangerous, and there are neurological diseases where falls are really very dangerous, and these people should not be anticoagulated, even if we have a reversal agent. Because as you heard, we have some conditions where people fall backwards, and you cannot protect these people from falling, unfortunately. Good, we all deserved lunch, and I would please ask you to come back at 1 o'clock. We have very important talks after the lunch break. Thank you very much.